Hi, good afternoon, everyone. Welcome to our webinar session titled Post-General Anesthesia Management and Post-Operative Pain Management, which conducted by School of Nursing and then Bachelor of Science in Nursing called 5B. Before that, let me introduce myself. My name is Lei Ming, moderator of today's speech. So I'm glad that welcomes to our guest speaker, Dr. Haslan bin Ghazali from KPJUCIAN'S, with his own topic post-general anesthesia management, and Dr. Chen, anesthesiologist, KPJ coaching, who will present on post-operative pain management. Here, I would like to share our objective to conduct this webinar. We hope that at the end of the sessions, the participant will be able to improve knowledge on the post-general anesthesia management and post-operative pain management to prevent and recognize post-operative complications, as well as conducting a comprehensive post-operations pain assessment, to use pain assessment tools effectively to identify and carry out appropriate interventions and in pain management. Before we invite our first speaker, I would like to share his biography. Dr. Haslan Ghazali is an anesthesiologist in KPJUCIAN'S Specialty Hospital. He did his undergraduate in medicine in USM 2001. He was a medical officer in the anesthesiology department in Hospital Tunku Fauziah, Perlis from 2002 until 2006. He then did his master in anesthesia in UKM in 2006 and graduated as an anesthesiologist in 2010. He served as an anesthesia in Hospital Lahad Datu from 2010 till December 2012. He was also appointed as Hospital Deputy Director in 2012, then continued his studies subspecialist in cardiothoracic anesthesia in Hospital Sudan in 2013 as well, and complete his fellowship seven until 2018. His interest in cardiac anesthesia, ECMO, and patient's blood management. He was awarded with World Excellence in KKM 3 times, also organized conference and taught nationally. Currently, he is the editor from the Malaysian Society and Anesthesiology Bulletin. Now, here, please welcome our special guest, Dr. Haslan Ghazali, with the topic post-general anesthesia management. I apologize because our doctor accidentally up from the link already, so we had to wait for a while. Actually, this today talk is very interesting for us and very beneficial for us, especially we know that we're handling a lot of patients, and then patients come to our hospital actually to get mostly of them is will go for operations. So actually, we want to make patient more comfortable. That's why post pain management is very important for that for us to deliver a good comfort for the customer. And then hope at the end of this session, you will get a lot of information from this doctor, and then we'll welcome you all to ask. Hi, doctor. So, doctor, you can start your speech.
Yeah. Hi. Hello. Sorry, I don't know why it just went out from this one. So, shall I share the slide again? I'll share the slide again. Okay. Are you seeing the slide? Hello?
Yes.
Yeah, can see the slides, yeah? Saya dah keluar. Nampak? Ada keluar slide.
Can you start, Doctor?
Okay. Assalamualaikum. Very good afternoon to everyone. I'm Dr. Haslan Ghazali, anesthetist in KPJ Pahang Specialist Hospital. So I've been in KPJ Pahang for roughly about 2 years. Was in Hospital Sedang before. So my topic for this afternoon is post-general anesthesia management. I hope I'm targeting mostly nurses, I assume, because this slide is, I've tailored it to mainly to help with nurses in managing post-op post-anesthesia. And I'm touching on the post-general anesthesia, ya. Tak apalah, saya campur-campur sekali kan dengan bahasa Malaysia boleh. So saya target post-general anesthesia saja. Saya duk fikir nak masukkan spinal, sedation, local ke, tapi saya rasa setengah jam a bit too short lah. So saya akan touch mainly on general anesthesia punya post-op management and monitoring. Okay? Alright. Okay, so what is general anesthesia? Basically, how to manage and care of a patient who has undergone operation under general anesthesia. Okay, so from the moment patient bangun daripada operation, ya, waking up from general anesthesia sampai balik ke ward, and how is being managed dekat ward. Okay, so when we say general anesthesia is when patient is intubated, you know, and connected to the general anesthetic machine. Okay, so what is when we say general anesthesia, okay, there's a triad, okay, atau 3 komponen penting yang mendefinisikan general anesthesia lah. Jadi kita kata general anesthesia, so dia ada analgesia yang bahagian atas tu, lepas tu dia ada hypnosis atau anesthetic, okay, yang menyebabkan patient tidur, dan dia ada muscle relaxant atau relaxation. So when we say analgesia, pain relief kan, so masa patient buat operation semua, patient mestilah diberi ubat tahan sakit kan. So antara ubat yang kita pakai, morphine, fentanyl, petidine, remifentanil, you know, paracetamol IV. Sekarang ni PCM dah ada IV, and then parecoxib, okay, Dinostat. These are among the analgesic that we use. So most patient under general anesthesia will receive either one or more of these analgesics. Okay, so later we will try to manage this patient based on what kind of medication this patient are receiving. Second would be the group of hypnosis atau ubat yang menyebabkan anesthesia atau patient jadi hilang kesedaran. So antaranya yang common kita guna propofol, thiopentone yang sekarang ni dah jarang guna, midazolam kalau patient on sedation atau patient having issues yang kita tak boleh guna propofol, kita pakai midazolam, dan also inhalational agents macam sevoflurane dan desflurane. Okay, so these are the medication atau ubat yang menyebabkan patient maintain dalam keadaan anesthetic atau tidak sedar lah sepanjang operation. Dan untuk memudahkan operation dan sebagainya, kita bagi muscle relaxant, okay, untuk relaxkan patient supaya surgeon senang untuk buat operation, ya. So antara ubatnya yang kita guna rocuronium, atracurium, pancuronium dan scoline. Scoline ni saxametonium yang kita dah jarang guna. Ya, banyak komplikasi dengan saxametonium. Okay, nanti saya sentuh kemudian lagi. Yeah, so basically general anesthesia, when talking about general anesthesia, is mainly consisting of these 3 main group of medication that we are giving to the patient to maintain this general anesthetic state of the patient, so that will facilitate surgeon to do the operation. Alright, so okay. So apakah among the common side effects of general anesthesia? Ya? Okay, saya ambil diagram ni sebab we just explains very simple. Okay, saya tak tahu kenapa ada gambar patient bagi spinal tu, tapi generally patient akan ada cognitive dysfunction, kan? Patient mamai, macam confusion apa semua tu because of the anesthetic drugs. Walaupun patient dah bangun from operation, they still get a bit of macam delirium, confusion. Sore throat, this is most common in a lot of patient because kita masuk tube, ya, kita masuk LMA, kita masuk ET tube, so masuk ke tekak. So this cause a bit of trauma, can cause sore throat, throat irritation. Okay, so Even so, kalau patient yang difficult airway, yang kita struggle nak intubate, cuba banyak kali kan, multiple times, lagi dah dia punya sore throat worse. Chills and shivering, okay, this is also common sebab patient dalam OT sejuk kan, so they have cold and shivering, that's why kita warm the patient. Headache, sometimes side effect of the medication, anesthetic can get headache, muscle pain, nausea and vomiting. Okay, nanti saya akan touch detail lagi lah in the next slides. Okay, so why we do intubate patient during anesthesia, endotracheal. So forget about the indication, okay, so untuk you all, saya rasa indication tak perlu. What you want to know is the complication. Okay, first, trauma to the teeth or oropharyngeal soft tissue. Okay, sekarang ni dengan video laryngoskop dan sebagainya, dan kita take good care of intubating the patient, so risk of trauma to the teeth or oropharynx tu dah reduce, minimize, banyak. But for new anesthetics, anesthetic MO yang baru belajar, so this incidents might be more lah in the in junior anesthetists. Okay, aspiration, okay, it can happen. Patient last meal tak cukup in emergency situation, tak boleh tunggu 6 jam. Patient ada obese, ada gastric reflux disease, patient pregnant, all this can incur aspiration. Hypoxemia, okay, kalau ada secretion a lot, ada airway obstruction, can cause hypoxemia atau saturation drop. Accidental extubation, bila kita dah intubate pun boleh terextubate. Kadang-kadang bila kita pindah ET tube, kita nak anchor daripada kanan ke kiri pun boleh terdislodge, boleh dislodge. Apatah lagi kita nak bawa lateral or in prone position. Okay, so accidental extubation can happen. Autonomic response, masih kita intubate, patient boleh dapat hypertension, tachycardia, bradycardia. Bila dapat vagal stimulation, boleh dapat bradycardia. Tapi most of the time is tachycardia and hypertension. Okay, tapi jangan terkejut, masih intubate tengok heart rate turun, BP drop, okay, because of vagus nerve yang banyak dekat area vocal cord. Okay, arrhythmias, patient boleh dapat arrhythmia. Bronchospasm boleh menyebabkan patient ada hyperreactive airway, patient ada URTI kan, patient datang ada sakit tekak dan sebagainya, they can easily get bronchospasm. Patient yang ada asthma, yang senang dapat bronchospasm, this kind of patient masa intubation apa semua can get. And also ET tube obstruction lah. Okay, so those were just some of the complications. Nanti kita go a bit detail, okay, on the complications, how you want to address in terms of monitoring and managing. So I will go straight to the point towards post-operative monitoring, okay, because to manage the patient post general anesthesia, you must know what is going on with the patient. Kita kena tahu monitoring of patient. Okay, so by the time patient habis operation apa semua kan, so patient will be monitored. Okay, so what do you see in post-op monitoring? Okay, so you have your vital signs monitor, okay, practically everywhere. Ada dalam OT, dekat recovery bay, dekat ward. Okay, so you have this vital signs monitor. So what does this consist of? So this vital signs monitor, okay, it measures the blood pressure. Okay, kalau kita separate kan empat komponen ni, so you have your blood pressure monitor yang monitor tekanan darah patient. Okay, bila patient undergo general anesthesia macam saya sebut tadi, boleh cause hypotension, hypertension. Okay, kalau ubat tahan sakit tak cukup, BP tinggi sikit kan, atau patient memang ada hypertension before surgery kan. So we have to monitor the blood pressure. We have to keep the good normal blood pressure in these patients. Okay, in general anesthesia will cause hypotension. Okay, about 10 to 20% of patients' normal blood pressure will drop during anesthesia, whether it's due to our drugs and medication or even the inhalational agent. Okay, then usually this blood pressure will start to pick up and normalize after reverse of the anesthesia. Okay, that's why we have to monitor the blood pressure. And then we part of monitoring the blood pressure is because we will come to a diagnosis of what is problem with the patient. Okay, so blood pressure selalunya kita tengok yang warna merah tu. Okay, kalau patient ada arterial line, dia ada arterial line waveform lah. Patient yang very ill yang kena ICU Okay, pulse oximeter kita kepit kat jari. Sekarang ni dia dah ada time COVID ni, kita boleh beli RM5 punya pulse oximeter lekat kan. Dia boleh keluar monitor macam dalam gambar kan. So tapi dalam OT dia kepit tu dia boleh ni lah nampak dekat monitor. Dengar jelas ya? Okey. Okay, so pulse oximeter antara another komponen yang kita perlu tahulah, saturation of the patient. Sebab we are managing the airway. Okay, kita masuk tube, kita sambung machine, kita paralyze the patient, machine yang batu pernafasan pesakit. So bila kita reverse the patient, kita nak make sure patient is bernafas dengan sendiri bernafas dengan elok. So kita nak make sure sebab patient kita dah cabut tube semua, so kita nak make sure oksigen cukup tak untuk patient. So SpO2 penting dan selalu bila pergi recovery tu saya akan suruh staff saya pasang SpO2 dulu. Kenapa? Sebab memang cepat dan mudah. Kita kepit jari dia keluar. Bukan saja keluar oksigen berapa persen, 98 ke 99 ke, dan dia keluar heart rate sekali. So dia dapat dua value kat situ saturation ni. Dengan hanya mengepit jari. Tapi kena careful lah. Jari kalau tangan operation kat tangan apa, kita boleh kepit kat jari kaki kadang-kadang dia ada pulse oximeter kat telinga pun ada dan sebagainya. Kalau cardiothoracic dia ada cerebral oximeter. Okay, so pulse oximeter yang penting untuk oxygenation. Third, ECG. Okay, so kebanyakan patient yang pergi general anesthesia ni kita akan sambung ECG lead 3 leads merah, kuning, biru. Merah, kuning, hijau, sasul. Okay. So benda ni penting sebab kita akan tengok dia punya QRS complex. Morphology of the ECG tu akan cerita kita patient ni okey ke tak okey. Rate of the ECG, arrhythmia ke kan. Saya kadang-kadang tak boleh tengok monitor, dengar slow, patient brady tengok dengar tik. Kita tahu patient brady without looking. Okay, so bukan setakat kita tengok, kita dengar. That's why monitor punya sound pun penting sebab dia bagi tahu kita patient is having arrhythmia. Kalau dengar dia macam arrhythmia, so kita tahu main dengar je. Tapi penting especially elderly patient yang ada comorbid, diabetic hypertension, ada heart problem kalau macam cardiac patient dia pasang sampai 5 lead ECG more detail. Okay, the most important is lead 2. Okay, so sambung ECG. Okay, tapi sebab benda ni semua take time, nak pasang BP cuff semua take time, so hubung yang pulse oximeter dulu, get your oxygen first. Okay, and then your respiratory rate, tengok pernafasan. So kelebihan monitor kita sekarang ni, bila kita sambung ECG lead, dia ada plethysmography, dia boleh tengok patient punya chest rise apa semua, it will give you the respiratory reading. Kalau tengok monitor ni, dia yang warna kuning itulah, nombor 14 kan, it tells you the respiratory rate. Okay, so this is what you get from the vital signs monitor lah. Sekarang ni dia cipta canggih, they have all these component. Kita sambung je wire lead ke patient. Okay, we have temperature juga. Selalu kat OT kita tak buat temperature monitoring, tapi kalau kat ward it's good to have the temperature of patient. Sekarang ni benda common lah, saya pun ada kat rumah 2-3 biji COVID kan, kita nak check, balik je check, tembak. So temperature is important. In patient in general anesthesia, lagilah penting kita nak make sure, sebab kita nak make sure patient kept warm. Okay, nanti saya explain lah why we need to keep patient warm, comfortable. So there are sublingual thermometer, ear thermometer, ataupun yang sekarang ni time COVID yang famous, yang tembak kat dahi itulah. So apa-apalah as you get the reading. So thermometer is also, temperature of the patient is also one of the monitoring that we do. Okay, so ni saya sambung cerita tadi dekat OT recovery, patient keluar kan, dah masuk kat OT recovery bay. So pulse oximeter is quick and fast to connect. Senang je, kepit kat jari, berapa saat je, give saturation and heart rate. So dua komponen dah dapat. Blood pressure ECG, ECG monitor, blood pressure cuff and respiratory rate. Okay, yang ni penting blood pressure, make sure guna cuff yang sesuai. Okay, sebab ada banyak cuff. Kalau tengok gambar tepi tu, banyak color, banyak size. Tak boleh pakai patient badan besar, pakai cuff yang kecil. So dia akan bagi cuff tu tak boleh inflate pun sebab kecil sangat kan. Kalau dia inflate, kalau cuff kecil untuk patient besar, dia bagi high reading. Kalau cuff besar untuk patient kecil, dia bagi a very low reading. Macam kita ingat hypotensive. Tapi sebenarnya cuff size tu tak sesuai. Okay, so proper cuff size is important, proper cuff placement. Okay, we have to make sure letak dekat dia punya lengan properly. Tapi kita kena tengok, okay, some patient ada AV fistula, we cannot put it there. Okay, patient ada AV fistula, we cannot put the BP cuff dekat fistula hand. Okay, so always make sure. Kadang-kadang patient datang OT dia dah ada stiker, so do not touch this hand, sebab dia ada AV fistula. Patient yang ada drip, IV drip running kan, dekat tangan tu, we cannot put the BP cuff. Especially if patient having inotrope ke or very important medication yang running. So BP cuff will hinder the kemasukan ubat patient. Okay, so we use another side, tangan yang tak ada branular ataupun kat kaki apa semua. Ya, ataupun side of surgery. Patient dah buat operation tangan tu, takkan kita letak BP cuff kat situ ya. Okay, satu lagi yang kena tahu, BP cuff dia akan bagi reading yang berbeza tangan dengan kaki ya. Selalunya BP cuff dekat kaki tu dia akan bagi reading yang lebih tinggi lah banding dengan upper limb. Okay, selalunya difference about 10 to 15 millimeter mercury. Okay, jangan terkejut pula letak kaki, asal lagi tinggi ni. Okay, sebab kita letak kaki ya. So, normal physiology, BP dekat sebelah kaki dia akan lebih tinggi sikit daripada upper body, daripada lengan. Okay ya. Setakat ni okay ya. Tak apa, nanti kita simpan soalan di penghujung rancangan ya. Prop up 30 degrees. Okay, ni saya selalu cakap, okay, kita naikkan kepala sikit, prop up 30 degrees ya. Especially patient immediately kat recovery tu, kita akan prop up the patient. Okay, provided there is no contraindication. Okay, patient yang sedated kita tak nak prop up ya, sebab dia tak boleh protect airway dan sebagainya. Okay, patient yang buat neuro atau spine surgery apa semua, surgeon akan marah kita head up sikit apa semua kan. Ataupun patient ada femoral catheter apa semua kan. Double lumen dekat femoral ke, atau patient post PCI kat femoral ke ya. So these are the patients kita tengok. Sebelum doktor kata naikkan patient sikit, naik 30 degrees roughly lah 30 degrees. Kita tengok patient boleh tak kita nak prop up. Kadang doktor pun salah ya, dia ingat boleh je semua patient, tapi sebenarnya kita tengok keadaan patient baru spine surgery atau ada spine injury, takkan kita nak prop up 30 degrees, betul tak? So the elevation of head of bed, prop up 30 degrees is to a semi-recumbent position is to associate with decreased incidence of aspiration. Okay, bila kita prop up sikit, patient risiko untuk dapat aspiration reduce. Bukan nak kata tak boleh boleh, tapi much reduce. Dan kalau patient intubated apa semua, reduce the ventilator associated pneumonia. Okay, dan also reduce splitting of the diaphragm. Patient yang obese perut besar macam saya ni, dia akan split the diaphragm. Bila saya baru susah nak nafas, tapi bila kita prop up sikit, dia rasa lega sikit. Sebab perut dah ke bawah. Macam Dr. Siva, perut ke bawah sikit dia rasa lega. 30 darjah cukup dah. Okay. Ya, antara kelebihan. Tapi kita kena make sure, boleh tak kita head up sikit. Part of ventilator care bundle, nanti saya cerita, is to prop up the patient 30 degrees. Okay Print tekak. Sorry sebenarnya. Okay. Sambung. Okay, keep warm patient. Okay, yang ni penting ya. Dalam OT sejuk, kat recovery pun sejuk, kurang sejuk daripada OT sebab dekat luar kan. Tapi masih sejuk. Jadi penting untuk kita keep warm patient. Okay. Kita boleh guna warming blanket or devices. Macam kat OT dia ada bear hugger kan. Okay, kalau kita running blood ke transfuse, dan kita boleh guna warming device dekat dia punya drip kita ada baki dan sebagainya kita boleh warm the blood sebab benda-benda sejuk tak bagus pada patient So why hypothermia bila patient sejuk, what it cause? Delayed reversal of anesthesia. Kalau patient sejuk, that's why a lot of people kalau prolonged surgery operation, dia akan letak temperature probe. Nasal temperature probe, chest temperature probe, just nak monitor temperature of the patient sepanjang operation. Sebab kalau patient exposed to a cold environment for long, hypothermia, so what happens? Reduce metabolism. Bila reduce metabolism, ubat anesthetic kita semua tu lambat untuk di breakdown. Badan kita, bila kita dah off gas, kita dah start bagi bahasa relaxer apa semua, badan akan start breakdown ubat-ubat ni untuk di-excrete. So, bila ubat-ubat ni dah dipecah dan di metabolismakan, dan patient akan mula sedar dah bangun lah, dah tak paralyzed kan. So, bila patient sejuk, benda ni delay, jadi slow. Metabolism is reduced. Dia jadi slow. So, bila slow, patient lambat bangun, patient lambat nak bernafas, antara faktor lain, bila patient sejuk, delayed wound healing, okay? Hypothermia, because of reduced metabolism apa semua, delay wound healing post-operative. Okay, so that's why antara reason kita kena make sure patient keep warm. Shivering bila sejuk, masa patient ada general anesthesia, dia tak ada shivering ni sebab kita paralyzed. Betul? So dia tak boleh defend daripada kesejukan apa semua sebab kita kena warming blanket. So bila patient dah start sedar, dah bangun, dia akan shiver tau. Dia akan rasa discomfort, rasa tak selesa, menggegar, menggeletar kan, kesejukan. Okay? That's why sangat penting kita keep patient warm. Kadang-kadang balik ward pun kita try to put blanket and keep patient comfortable lah. Okay, in pediatric patient, okay, saya sentuh sikit Okay, kanak-kanak ni dia special sikit bila kita deal dengan saya takkan sentuh pre-op ke apa lah, intra. So bila kanak-kanak dia dah bangun dia akan restless tau, sebab bila kita bagi tidur tu, okay, dia tak sedar apa semua, bila dia bangun tiba-tiba dia tak kenal kan, dia tengok muka semua, bukan ada mak bapak dia kat situ, ada muka doktor, nurses yang dia tak kenal, semua pakai mask. Budak-budak biasalah, dia akan takut kan. So kalau boleh bila sampai recovery tu, kita dapatkan mak atau ayah dia, atau penjaga, nenek dia ke apa, orang yang dia familiar. Okay, especially bila dia dah bangun sedar. So in a way it gives them more comfortable and keeps them they feel less threatened. Okay, rasanya yelah budak kecil 5 tahun 6 tahun kan, duk tidur elok sedar, bangun tengok mana mak, mana abah kan kita jadi restless kan, jadi macam tu. So try to get their parents to come to OT, comfort them. Okay, is penting to keep them calm and relax. Okay, because bila dia restless apa semua, mulalah tercabut ranula kan, dressing tercabut, kalau dressing kat mata nak cabut kan, semua kan jadi ni. Lepas tu kalau dia bebal kan, dia boleh injure diri dia kan atas katil tu. Walaupun kita naikkan rail apa semua, dia still boleh inflict injury. So budak kita kena careful sikit. Keep warm, benda-benda lain jugalah. Monitoring apa semua. Kadang-kadang budak susah kita nak buat ECG apa semua, bubuh pulse oximeter pun dah okey dah. Pulse oximeter. Lepas tu balut dia, keep patient warm. Okay, kalau budak tu tak sedar elok lagi, kadang-kadang kita tak tunggu budak dia bangun fully awake dekat OT, dia dah bangun, kita cabut tube, tapi dia masih dalam keadaan tidur, tapi pernafasan semua okey, tapi dia tak fully awake, maknanya dia tak restless apa. Okay, kita push recovery, kita put in lateral position, okay, supaya kalau ada secretion apa semua, it will avoid aspiration. Okay, keep calm and relax. Panggil mak dia datang sebelum dia mula sedar dan meronta-ronta. Mak dia datang, bila dia buka mata tengok mak dia, okey kan. Okey, ini generally in kanak-kanak lah. Okey, pain. Okey, pain is the fifth vital sign. Saya tak sentuh sangat pain sebab nanti Dr. Chen akan cerita kat you all. Okay. Dia introduced by MOH 2008. Okay, dan dengan ada dia punya stress strategies lah. I think most hospital in Malaysia sekarang ni dah adopt the pain as the fifth vital sign lah, okay, in the country. So what are the benefits? Okay, better communication lah, better patient satisfaction. Okay, kita sebagai anesthetist, kalau post-op, saya akan pergi round patient, usually the next day ke apa, to see how the patient doing. Okay, saya tak ada pergi bawa card, how are you feeling? This one ke, 2, 3, tak. I just talk to the patient. Okay, when you talk to the patient, in a way you tanya, okay, macam mana sakit tu, macam mana, okay ke, boleh tahan ke, duduk okay, batuk ke, sakit lagi ke, sakit lutut tu masih ni ke, post-spinal ke apa. But we, in a way, we are creating rapport with the patient, we are communicating with the patient. Just by asking them, will reduce the pain. Betul tak sih? By talking to them is actually a way of relieving the pain. Okay, better patient satisfaction. Priority to pain assessment, maknanya kita show concern about patient's pain. Okay, individualized care. Okay, different patient have different pain threshold and different mode of treatment. Itu Dr. Chen akan touch lebih detail lah. Faster recovery, and also ni penting, reduce length of stay. Reduce hospital stay dan sebagainya. Okay, ni contoh pain measurement scale. Okay, yang itulah yang ada banyak lah, nanti Dr. Chen akan tunjuk lah ni Dr. APS nurse dekat UK dia nak buat. Okay, siapa? Malaysia dia. Nanti tinggal bahas. So when you receive patient from theatre, okay, you receive dekat airlock tu, so there'll be a review of patient record. Okay, kena hand over lah. Ya, OT nurse akan pass over kan, ward nurse beritahu what happened, ada checklist dan sebagainya. Okay, monitor the patient vital signs, okay, yang saya sebut tadi lah. So berapa kerap kita nak monitor bergantung pada keadaan patient tu, ya. Patient tak bagus, kritikal apa semua, kena kerap sikit monitor. Kalau patient yang major operation, kena kerap sikit 15 minutes. Lepas tu for the first 24 hours later boleh ni lah. So different patient depend on selalunya doktor akan order lah. Okay, try review more apa tu frequent. Okay, check the surgical dressing, oozing or bleeding. Lepas tu tengok the surgical drain, banyak tak drain. Tanya patient about pain and observe general condition of the patient. Okay, by talking to the patient you can get this. Okay, so what are the surgical complications? Ini kita go a bit about detail lah sikit ya. So sorry post-operative bleeding, okay, it can be visible or concealed. Concealed tu kalau kat dalam perut ya, patient makin besar atau compartment syndrome kan, nampak ketat apa semua. Kalau dalam abdomen dia makin tight. Kita tak nampak tapi kat dalam tu kita tahu perut makin besar, kita tekan tense apa semua. Must be a bleeding inside. Okay? Kadang-kadang dah ada drain tapi drain tak keluar. Drain tak keluar apa pun. Kadang-kadang drain block. So bila dia tak keluar kat drain, dia keluar kat perut, dalam perut kan. So it is concealed. Visible macam kita tengok lah, oozing, soaking dekat dressing. Nampak makin baru je balik daripada OT, baru 5 minit. Tengok merah dah soaking drag. Maksudnya ada active bleeding, ya. So there is and then tengok drain, ya. Baru sampai 5 minit, drain dah naik 100 mil, 200 mil, kan? So we have to watch out for this. Hemodynamic instability, ya, post surgery ni, dia punya BP can be labile, ya, can be hypertension, ya. So we have to based on the monitor yang kita santum tadi lah, ECG, BP apa semua kan. Conscious level pun penting, ya, conscious level. Infection ni a bit later lah, ya. Infection surgical wound inspection dan sebagainya to see on the surgical side and also cannulation side, ya, not just the granular but patient ada CBD, ada central line, line ke whatever, you have to make sure that there is no redness, inflammation, swelling apa kan, because these are the telltale signs that is going to be infected in the future. Okay, ni gambar nurse pula yang tengah check ni lah, dia nampak macam air sirap je lah. Okay, we go to anesthetic complication. Okay, so sebab kita nak GAN. Okay, so oral trauma. Okay, so senior NS mungkin we try to avoid this from happening lah. Masa intubation apa semua, we will avoid causing bleeding, causing trauma. But kita manusia kan, kadang you have a difficult airway, you can't get away from causing a bit of injury, bleeding sikit, broken tooth, ataupun unremoved throat pack. Okay, ini pernah berlaku dulu lah kat kawan saya masa junior ya. Patient dah extubate apa semua, dah masuk ICU. Dia patient macam gagging, rupanya ada throat pack, tak keluarkan lagi. Okay, so most important. Tapi nurse dekat OT very good, dia akan make sure throat pack dikeluarkan dan dia akan catat pukul berapa throat pack dikeluarkan. Okay, airway obstruction, ya, secretion, patient smoker, chronic smoker banyak secretion. Ya, tak tahu kenapa. Patient yang isap rokok berkumpul-kumpul, berpack kan. Dia masuk OT je, banyak secretion, kena sedut. Kita sedut je, ada lagi secretion. Okay, so especially chronic smoker patient yang hyperactive airway, they can have lot of secretion. So you must make sure sedut betul-betul. Okay, oral surgery, tonsil ke apa, so they can get obstruction. Patient yang ada OSA underlying, ada lidah besar ke apa, senang dapat obstruction. Okay, nerve injury, neuropraxia. Okay, ni boleh berlaku juga, ya, ada compression pada nerve. Saya ada one patient juga, dia dapat lingual nerve neuropraxia, ya, compression of ET tube on the lingual nerve causing neuropraxia, atrophy of this. So it can happen, ya, walaupun benda ni rare. Okay, positioning of the patient can cause limb numbness, foot drop, eye injury. Ya, patient on lithotomy position, kena make sure position betul, patient boleh dapat foot drop. Patient in prone position, mata make sure is free, dia tak compress. Ya, patient boleh dapat blurring vision, blindness because of bila-bila lagi patient spine surgery in prone position, lama pula tu, berjam-jam, tengok mata compress. So you have to be careful, okay? So you have to check, ya, dia punya visual okay, foot drop tak ada, numbness, ada numbness or pain anywhere in the limbs. Residual sedation, residual muscle paralysis can happen, walaupun patient kita dah reverse dah muscle relaxation, dah reverse sedation semua, but mungkin ada ubat ni still dalam badan pesakit tu, okay, which may cause some effect. So we have to check conscious level, make sure there's no respiratory depression, pernafasan is okay. Medication side effects, morphine, we can cause delayed respiratory depression, itchiness, okay, banyak patient kita yang kita bagi intrathecal morphine saja pun mengadu gatal-gatal, tapi selalunya kita akan bagilah anti-emetic, anti-pruritus, piriton dan sebagainya. LA toxicity, kalau general anesthesia kadang-kadang surgeon yang bagi LA, so we have to make sure patient tak ada side effect of lidocaine, toxicity apa, patient boleh dapat dyskinesia ada, okay, dan pelbagai masalah lain lah. Nausea vomiting ni sangat common, banyak medication anesthesia kita yang cause nausea and vomiting, so kita akan bagi ubat anti-emetic lah, Maxilon ke, Eloxy ke, Zofran apa, dan Kytril dan sebagainya lah, adalah banyak dalam market, okay, untuk prevent nausea and vomiting. Okay, dyskinesia, abnormal, uncontrolled movement, this one can happen especially post-general anesthesia due to propofol, due to anti-emetic can cause, due to LA toxicity, they can have so this kind of response in patient, post-operative, okay, so kena ni. Allergic response, okay, patient yang tak pernah ada allergy pun can have allergies towards antibiotics and analgesia, okay, these are the two main drugs that mainly cause allergic response lah, allergic reaction, sebab dia ada histamine release, okay, ada opioid, mainly opioids, ada histamine release can cause allergic response, dan kebanyakan antibiotik yang sulfur based dia akan cause allergic reaction. MH, malignant hyperthermia, ini saya pernah experience diri saya sendiri masa saya kat Perlis, patient can pass away, malignant hyperthermia, okay. Ini antara komplikasi anesthesia yang sangat fatal, boleh menyebabkan kematian, okay. But usually this kind of patient is immediately identified kat OT and managed. Dan this patient never go back to a ward lah, dia akan masuk ICU, dia akan di actively treated, actively managed, intubated, lines dan sebagainya, cooling down, dan dia orang demam, temperature very high. This kind of patient, malignant hypothermia, nama pun hypothermia, patient panas badan, panas membakar. Dia bukan macam patient keluar daripada GA, daripada OT sejuk, dia orang panas badan, hypothermia, dia orang punya metabolism naik, CO2 production increase, okay, so dia hypercatabolic state, dan dia orang di-treated with dantrolene, hanya dantrolene yang digunakan untuk treat, okay. Dan saya unfortunate pernah ada masa saya junior MO dulu, ada one experience of patient malignant hypothermia, okay, dan this patient selalunya malignant hypothermia is triggered by succinylmetonium and inhalational, so that's why sekarang ni kita tak pakai sux, tapi inhalational can cause malignant hypothermia as well, okay. Sorry, ada few slides. Okay, so basically gambar ni tunjuk what are the general overdose symptoms, okay, dementia, hallucination, hypothermia, fitting, nausea, vomiting. Some medication can cause fitting, tranexamic acid, apa semua, they can cause the blood-brain barrier, they can cause seizures, okay, so you have to watch out lah for all these symptoms. Mental, okay. Management, okay, first call for assistance lah. Okay, call for help. Okay, kalau kita seorang kat situ, call for activate rapid response team atau code blue if necessary. Patient unconscious, nampak macam no response pun, just activate code blue. Okay, inform the primary doctor. Okay, ni minta kawan lah, kawan inform the doctor atau surgeon, kan, surgeon yang baru operate, so, and inform the anesthetist. Okay, so that we know about the problem and we can come and manage immediately. Okay. And kalau kita rasa is bleeding a lot, kita nampak is oozing banyak daripada surgical site, kan, daripada draining banyak, so you think is a patient anemic, nampak pucat apa semua, kan, so run fluids. Kalau kita ada blood, run blood, kalau kita ada colloid atau crystalloid, boleh bagi gela ke, Harmon ke, apa benda yang kita ada yang kita boleh grab run fast. Okay, sebab patient ni is hypovolemic. So to prevent dia going into hypovolemic shock, kita treat very fast. Tak payah tunggu doktor nak datang apa semua, kita rasa ni, do the right thing, run fluids. Okay, whatever that you have. Okay, if patient hypoxia, macam respiratory depression, nampak sedih, tak nafas sangat, saturation drop, bagi oksigen. Kalau ada nasal prong, bagi nasal prong, kalau ada high flow mask apa semua, prop up the patient kan. Kadang-kadang patient besar, obese, baring macam tu, splitting, prop up the patient kan. So dia tarik nafas dalam-dalam. What I always tell the patient, breathe in deeply but breathe slowly. Bila patient nafas laju, oksigen tak sampai. So breathe slowly, so dia relax. Kadang-kadang dia anxious ke kan. Give a bit of nasal prong kalau ada to help with this one. And then kita monitor more frequently vital signs, especially patient yang dah ada all the symptoms, ada problems semua. So kita monitor more kerap. Kalau patient yang tengah collapse, even 5 minutes kita buat BB cuff monitoring apa semua. So we have to more frequently. Until kita patient dah stable, then you can jarakkan monitoring. Okay, stop medication if you think it's an allergy or reaction to the transfusion. Tengah bagi blood, tengok patient dapat reaction, ada urticaria, naik gatal-gatal semua kan. So stop the okay. Sorry saya pergi cepat last few slide. Okay, in critical or unstable patient, yang ni patients are managed in the ICU, HDU, post-op. So these patients may have invasive monitoring, CBL, bukan red line, salah spelling, line, CBD. Okay, so penting untuk kita jaga all these lines. A patient may be intubated and ventilated post-op because tak stable. So have to take care of the ET tube, ventilator. So ventilator care bundle, okay, yang ni kalau ICU staff dia tahulah what is ventilator care bundle, ABG monitoring, tengok oxygenation dan sebagainya. Patient may be on inotropic support, so make sure line yang masuk inotrope semua tu tak king, tak block, tak off dia punya machine, make sure it's still running well. So this patient ada line, so you based on your inotrope, based on the blood pressure. So management of inotrope and vasopressors ni lain hari, lain rancangan lah, itu satu big topic. Okay, patient may be high on sedation and anesthesia, especially baru post-op dan tak stable, so they may be highly sedated and on highly dose of morphine or something. So we have to monitor for any side effects. Alright, so sorry lah kalau terlajak sikit saya ni kalau cakap ni tak habis cerita, so sebab tu saya rasa macam nak masuk spinal semua tu tak sempat. So saya touch on general, ini pun saya rasa tak banyak ni. Hopefully this will help you guide as nurses lah, it will be helpful. Saya ada masukkan tips sikit, what you should do and don'ts dan sebagainya. So thank you very much, thank you for listening and have a nice day. Have a nice day. Terima kasih. Okay.
Yes, sir.
Boring, huh? Tell you bro, when I start talking, it's like okay. Okay. So saya stop sharing ni macam ni. Stop sharing
Thank you, Dr. Haslan, for your informative talk. I hope you are enjoying these imagine presentations. Now we open for question and answer sessions. So I share one question which was shared in the chat box. So the question is, doctors, we keep patient warm, but OT terlalu sejuk. Bukan patient saja, tapi staff pun sejuk. Kenapa, doktor?
That is true. That's why I wear jacket. Very cool. Very cool. Okay. So Okay. So, how? Okay. The question is that why we have to keep the OT cold, is it?
No, because say that we keep the patients warm. But in the OT, the staff also very cold. So they say why the staff also feeling cold in the OT.
We can't help it lah. They will blast the aircon so high. The temperature is 18 to 20 degrees Celsius. It's very cold. It's very cold. So the reason is that they want to reduce the risk of infection. Okay, bila OT panas, humidity naik. You know, kelembapan naik. So bila kelembapan naik, the risk of spreading the infection is much higher. Okay, surgical wound infection is much higher. So they have to maintain the temperatures about 20 degrees in the OT to reduce the humidity. Ya, dia nak turunkan kelembapan dalam OT tu untuk mengurangkan risiko infection lah, surgical infection. So tapi memang saya pun memang pakai jaket, memang sangat sejuk. Kalau kat KPJ ni OT3 tu memang sangat sejuk. Saya dah complain. Does that answer the question? Hopefully.
Yes. Yeah. So I give another question. Is Chen.
All right.
They ask, Doctor, what causes post-anesthesia shivering? Because sometimes you see the patient after one come from OT during recovery, they keep on complaining of shivering. So what is the reason for this?
Okay. This is when it's patient not complaining of cold.
Yeah, patient not complaining of cold.
Okay. Okay, if you notice post-spinal anesthesia, they can get post-spinal shivering. Okay, there is a common known side effect of spinal anesthesia. They can get this type of shivering. When we ask them, patient tak sejuk, okay, yeah. But they get the shivering. It's because of the spinal. Can't really explain why they get post-spinal shivering. Okay, but generally after spinal or even general anesthesia, patient vasodilate. Yeah, so when vasodilate, blood vessel besar, easily lose the heat. They get shivering. But if patient is not complaining of cold or anything, normally is post-spinal, they can get post-spinal shivering. Sometimes we can give petidine 25 milligrams, they will stop the shivering. Okay. Yeah.
Okay, so means that after if never
how do you stop the shivering? I have no idea. Kappa.
Okay. So because of the time constraint, the rest of the questions I will share to Dr. Haslan later. So after we will answer in the group letter. So thank you, Dr. Haslan, for answering the questions. Hope all the nurses understand and have more knowledge on the post-general anesthesia and the management. Actually, it's very informative. So I also learned a lot, especially doctor also touched on the pediatric patients, because we not only care of the certain things like hemodynamic needs, we also need to concern about their psychology, like anxiety, and this we have to take care of patient as a whole. So thank you so much for your talk. So now we go to the second speaker. I will share the links, the attendance links in the group chat. So please enter your attendance list. Okay, now we welcome our second speaker, Dr. Chen, anesthesiologist, KPJUCIAN'S, who will present on post-operative pain management. Dr. Chen is a consultant anesthesiologist and interventions in KPJUCIAN'S Specialist Hospital. He obtained his MD from University Malaysia Sarawak in 2002 and completed Master in Medicine Anesthesiology from University Science Malaysia in 2010. Dr. Chen further pursued his training in pain management in India in 2011 and passed fellowship of interventions pain practice from World Institute of Pain USA in 2012. Dr. Chen also became a member of Academy of Medicine Mauritius in 2013 and is also actively in clinical research. He has published more than 15 scientific papers, including abstracts in the field of intervention pain management and regional anesthesiology. He has presented his works on research in conferences both locally and abroad. He is serving as an expert reviewer for international peer-reviewed journals, including Indian Journals of Pain and Korean Journals of Pain. Dr. Chen also has organized various pain management workshops for paramedics and clinicians, and then also Keynes facilitated the teaching interventions pain teaching technique in national symposium and workshop. Now let we welcome Dr. Chen for this topic, post-operative pain management.
Can you all hear me?
Ken, I don't think it's your turn already to.
I know. Yeah, I'm listening. Yes. Thank you, Lee, Matron Lee, and yeah, thank you, Dr. Haslan. It was a wonderful presentation. Can you hear my sound, my voice? Can you hear my voice? Can. Right, excellent. No. How about can you all see my slide? Can you all see my slide? Yeah, slide is not present here. Okay, can you see my slide? Berapa number slide saya? Anyone see my slide? Hitam je slide Dr. Chen. Hi. No, okay. So streamer is sharing a window. I'm sharing.
Okay, stop sharing first. Stop sharing.
Stop sharing.
Then we do. Okay, this one put down. You are in the show. Mute.
Okay, excellent. Thank you, thank you, Matron Lee, and thank you, Dr. Haslan, for just now a wonderful presentation on post-operative anesthesia management. I think beside our audience, I also benefited a lot from the presentation. It was a wonderful presentation. So I would carry on the topic for today's presentation with post-operative pain management. Actually, just now, Dr. Haslan also touched a bit, so there will be a little bit of overlapping. Once there's an overlapping presentation, I will skip some of my slides. So just bear with me for half an hour. It's not going to be too long. Next. So this is our new building. It has been here for almost 2 years. Newly built KPJ Hospital. Currently only 70 beds, but later on probably will increase up to double the size of beds. It's a tertiary center. It's very nice to work with. Okay. Next. So, operation is one of the most important service that a hospital provide. But when you talk about operation, patient will be frightened about the pain whereby they will experience after operation. So when we talk about post-operative pain, we need to know what patient are fear of and what is the impact of this pain to the patient. Because nobody likes to have pain. It is a very unpleasant feeling to the patient. And also, with the pain around, they will increase the surgical stress response. So all the physiological changes may affect patients' recovery. And because of pain, because of fear of pain, nursing care and also physiotherapy and rehab program all will not be able to carry out properly because patients fear when they move, the wound will be pain. And with that also, patient delays melambatkan mobilization pergerakan. If they don't move around after operation, more and more post-surgical complication will happen. We are talking about some serious complications, for instance, stroke, heart attack, and also DVT, like pulmonary embolism. And if patient refuse to mobilize due to pain, obviously they will stay in the hospital longer, which will incur more post surgical complications, like for instance pneumonia, bed sore, and on the other hand, this will increase the hospital bill for the patient as well. So next slide. If you can see from this slide, this is a presentation done not long ago, about 2014, by a Canadian group. They managed to analyze 3,000 pesakit lepas operation. So they happen to notice that if we do not address the pain properly and urgently, as high as 14.8% of patients will develop chronic post-surgical pain, which is very, very difficult to treat. So there you go. I'm here to enlighten everyone about post-surgical pain management. Next. From time to time, we have a lot of research reports about post-surgical chronic pain. So some of the major surgery, let's say for instance, thoracotomy. Thoracotomy maksudnya membuka jantung, membuka our rib cage and then open and to do the surgery around the heart or around the lungs area, dekat paru-paru atau jantung. As high as 65% of patients experience post-surgical chronic pain. And those with CABG, the coronary artery bypass surgery, as high as 50% also develop this kind of chronic pain. Not to say that hernias, mastectomy, and also amputation by the orthopedic surgeons, all these actually cause quite high, quite significant post-surgical chronic pain. That's why we are here to stop the progress of acute to chronic pain with our management here. Next. So the objective of post-operative pain management is to offer best possible pain relief at a reasonable cost and labor and without risk to the patient. So kita mau patient berasa kurang sakit atau tambah sakit without any harm, tak ada membawa risiko atau bahaya kepada patient, because all the medicine, all the technique we use may cause some risk to patient. So we try to balance out. Kurang sakit tapi kurang bahaya. And with that, we can achieve them to move early, sit up, stand on the feet, bagi tanda sendiri. And also, dengan itu, will improve, will enhance the recovery. And once they start moving, obviously, post-operative complications such as stroke, heart attack will be reduced as well. Next. So, this is a very complicated pain pathway. So when there's a cut in the tummy, for instance, laparotomy, the A fibers and the C fiber will be stimulated through the first order pain efferent and go to the spinal cord. So from there, it will go to spinal thalamic pathway going up to the brain, to the second and third order. So by the time reach our sensory motor cortex, whereby our brain will interpret as sakit, very painful, jangan gerak. If you gerak, sakit lagi teruk. So that's why That's how our pain signals come in from the very peripheral skin incision, skin cut, all the way up to the brain. So what should we do? If we know all this knowledge, we have this knowledge, we should address this one by one. Next, so our strategy, which will include the preemptive analgesia. So we try to modify the pain pathway. Just now I already show you how does the pain from the skin cut up to the brain. So we try to modify the pathway by you giving multimodal analgesia. Banyak jenis, banyak cara, banyak ubat untuk intercept, meaning that menghalangkan itu pain pathway, pain input. And with that, we will increase the chances of rasa sakit, increase the peluang patient berasa sakit. So patient even a little bit cut, they won't feel the pain. So lebih tahan sakit. And some of the ubat also will block the pain receptor activation. So langsung halang the pain signal daripada dihantarkan ke otak. So all this, because we have the knowledge nowadays, that's why we can provide all this strategy. Next slide. You can see from bottom, when there is a trauma, a cut by the skin, so usually the peripheral nerve will be traumatized, akan dicedera. So from there, we can give a few things, like we can give anti-inflammatory drugs, for instance, Cerebrex, Acoxia, or we can block the nerve by using our bupivacaine, Marcaine, or ropivacaine. So if that doesn't help, we can provide local anesthetic at the spinal cord level. What spinal cord level are talking about? Like for instance, spinal anesthesia, epidural anesthesia, boleh berkesan. And kalau itu pun tak bagus, then we give general anesthesia, whereby we give ubat, morphine, or propofol yang tadi disebut oleh Dr. Haslan. So apabila kita ada knowledge, we know what is the pain pathway, we know where is our strategy, how we go and then try to stop the pain daripada periphery, skin cut, all the way travel to the brain. Okay, I stop for a short while. May I know, anybody, can you listen clearly to what I say? Is my voice adequate enough? Any response? Dapat dengar? So far, is the voice dapat dengar? Can you all hear me?
Yes.
You can hear?
Yes.
Great. Okay, let's carry on. Okay, next slide, please.
Okay. Very clear.
Good. So for post-operative pain management, that include three things. Okay, three parts. We need to start off from pre-operative, and then intra-op you can play a role, and of course post-operative also it is very important. So what can we do pre-operatively? Next slide. So usually pre-operatively we play around with the ubat. So the ubat which we can provide, which can administer, yang boleh kita bagi termasuk opioids and NSAIDs dan local anesthetic. Next slide. We start with opioids. Opioids seperti dalam gambar ini. So there are morphine, fentanyl, petidine, and oxynorm. All these are intravenous agent. Maksud saya dibagi secara IV. So masa kita sebagai anesthetist, me and Dr. Haslan, when we induce the patient before the surgery start, we give all this ubat so that patient already have opioid dalam badan sebelum operasi dimulakan. So opioids actually bind by opioid receptors in the badan so that it will exert a lot all others activity dekat organ yang lain. We see next slide, okay? So dekat central nervous system, opioid boleh membagikan analgesia, tahan sakit. Analgesia means tahan sakit. Sedation, lebih kuat tidur. Then respiratory depression. Kalau if you give too much of opioid from sedation, patient will become respiratory depression. Maksud saya, dia kurang bernafas atau berhenti bernafas kalau terlalu banyak kita bagi. Then side effect dia termasuk yang excitatory side effect, nausea, vomiting. Bagi terlalu banyak petidine atau morphine boleh dapat nausea, vomiting. And patient akan jadi high. High bermaksudnya euphoria. Dan anak mata akan jadi besar. Anak mata macam busa. So the mata will be blur. Okay. Dekat cardiovascular system, if we give opioid like for instance morphine, patient punya salur darah akan vasodilate, akan berkembang. So you sometimes get the face a bit flushing. And then because the salur darah berkembang, so blood pressure will be coming down. That's why it causes hypotension. Some patient may allergic to morphine and increase the histamine release, whereby again it will cause more hypotension and also have a little bit on heart rate. Bila sakit kurang, heart rate daripada tachycardia boleh jadi normal balik atau sometimes a little bit of bradycardia. And of course, dekat perut, morphine atau opioid boleh reduce mobility. That's why kadang-kadang boleh jadi ileus lepas laparotomy. Belum berkentut atau tak ada pass motion. So this kind of thing can happen if you give too much of opioid. And then increase gastric emptying time, maksud dia sepatutnya 4 jam boleh cerna, tapi ambil mungkin 8 jam baru cerna makanan. So it slow down everything in the gut, dekat usus besar atau usus kecil. And then of course can sometimes cause biliary spasm as well. Next slide. So another drug that we always give, this kind of drugs we can give is the NSAID. So beberapa contoh macam ni, Cerebrex and Acoxia is in the oral form. And then in the diagram, yellow diagram, Dynastat is IV form. I usually like to give Dynastat to the patient for major operation if there's no contraindication, tak ada kidney failure, tak ada heart failure, boleh bagi dia. It's very effective and then it's a long acting, tahan 8 sampai 12 jam. So of course dekat budak we can give ibuprofen, diclofenac oral atau kadang-kadang boleh bagi suppository boleh. So basically, NSAID inhibit the cyclooxygenase and also prostaglandin. So that's how the mechanism. To stop the pain pathway. Next slide. And like I say, selain daripada some weak NSAID, for instance, the paracetamol, nam come out with the IV seperti dalam gambar intravenous. So separuh jalan during the operation, I always like to give IV paracetamol 1 gram for adult patient because multimodal, selain morphine, selain NSAID, we semua campur sekali, it will add on the synergistic effect. So it's not like 1 + 1 = 2, it's 1 + 1 = 4. The effect of a pain relief will become 4-fold, 4 kali ganda lebih bagus. So of course, kalau kita tak berhati-hati, NSAID can cause gastric complication, kidney complication, and also platelet dysfunction. Banyak orang juga allergic to NSAID, for instance, the Wartaran, the diclofenac Wartaran atau Cerebrex. So all these are allergic history we need to ambil baik-baik sebelum operation. Next slide. Next, we talk about local anesthetic. So local anesthetic can be given at multiple level. Dekat skin infiltration, dekat spinal, or dekat nerve block, semua boleh bagi. So because basically it blocks, halang transmission of the signal, pain signal dari tempat sakit terus ke otak. Oleh itu, you rasa kebas, tak ada kesakitan. So that's how it works. And like usual, the short acting one ada lignocaine, long acting one ada marcaine, ropivacaine, dan chirocane. So the gambar yang terletak is a chirocane yang lebih baru ini, okay? So can be used in multiple epidural spinal nerve blocks, okay? And sometimes in order to make the block last longer, kita tambah sikit opioids macam morphine, macam sikit fentanyl. Itu akan jadi lebih selesa patient and lebih tahan lama. So it will block the sympathetic, will block the touch and block the pain, and akhirnya block the motor. So patient kaki langsung tak boleh bergerak kalau the kekuatan of the block is cukup high enough, cukup tinggi. Next slide. So as an anesthetist, we always try to provide a good pain relief intra-op and post-operative. So back in 2016, KPJUCIAN'S sudah run a few studies to show that we are trying to provide best anesthesia service to the patient, both in terms of the post-operative management. Like for instance, we do our orthopedic sites are very active. We have a lot of orthopedic case. For instance, those elective TKR, knee replacement surgery, and sometimes we even do bilateral together in one setting. So we actually created a protocol by giving a slightly higher dose of spinal together with femoral nerve block in order to provide adequate anesthesia time and also to provide adequate post-operative pain relief without causing delay in mobilization, without causing delay in physiotherapy. So this is a study we published in the America, 2016, together with Dr. Francis Lau and Dr. Lee, orthopedic surgeon. So it really actually helped the patients a lot, both in terms of pain relief and also blood loss during the operation by just giving single dose of spinal. And of course, post-op, we do provide the femoral nerve block for the post-op pain. So next. And in terms of laparotomy, we also do a lot of abdominal block. So because this abdominal block and just on the spinal are considered preemptive analgesia, we try to block the nerve sebelum operasi mula, sebelum luka dibuat, sebelum before a cut is made. So like for instance, colostomy and reversal colostomy dekat budak yang very kecil, 3 months, 4 months or less than a year lah, neonate. So we do a tap block dekat perut. So patient bangun tak menangis terlalu kuat. So it's just awake and then patient doesn't require so much of opiate. Opiate maksud saya morphine, because this group of patient budak kurang dari 1 tahun, we are worried that morphine bagi terlalu banyak, patient tak mau menangis atau tak jaga, terlalu kuat tidur. Sometimes we may miss patient, maybe apnea in the ward. That's why we do a lot of regional anesthesia for young age of patient as well. Together with hernia repair, also we do tap block and also inguinal field block. So patient recover faster, tambah terlalu kuat tidur, and then sometimes day case surgery discharge dia dekat petang. Next. For adult also, we also do a lot of tap blocks for open cholecystectomy. All this reduce the need of painkiller post-op. So and also increase the early patient gerak awal sikit, because perut sudah kebas, not so painful tempat yang dia dioperasi. So this will help a lot. Next slide. We even compare the result. Next slide, please. We will also compare the block together with just given morphine. So obviously, those patients with a block, it will recover faster and do better in terms of pain score and also early discharge, hospital stay. So because we compare also tap block with just given IV morphine, there's significant difference, both in terms of pain score post-op and also this analgesia usage. Because some patients when they sakit, mereka akan tekan, they'll ask for pain relief. So we can judge from that. Boleh kira tengok, patient ni gerak sangat minta IM petidin, gerak sangat minta Cerebrex. So this kind of thing can tell there's a difference between the blocks and also yang tanpa blocks. Next patient, next slide. And we always try to improve. Sebagai anesthetist, we always try to improve. Just now I presented a presentation about femoral nerve block. But baru-baru ini, the trend already moving away because femoral nerve block, we also noted that patient having muscle weakness. So nowadays, I also try to provide adductor canal block for the knee replacement surgery. So adductor canal will spare the quadricep muscle, yang those hamstring muscle. So patient akan jadi kuat balik on the next day, day 1 post-op. Oleh itu, day 1 post-op boleh terus berdiri dan berjalan untuk melakukan fisioterapi. So this one again early ambulation supaya boleh discharge awal. So this is one of the adductor canal block yang saya lakukan semasa di OT dekat after operation recovery dekat recovery bay. Next slide. So those are pre-operative management. Intraoperative management is also very important. Why is that? Because next slide. If a surgeon choose minimally invasive versus an open surgery, yang di atas ialah minimally invasive, we are providing a laparoscopic 3D system dekat KPJ Kuching. This is the one of the first facility yang kita ada dekat KPJ Kuching. So one of our gynecologists are performing a hysterectomy by 3D system, laparoscopic hysterectomy. So patient basically discharged next morning because pain is very much reduced, blood loss, everything is reduced. The wound is so minimal. But comparing to the photo at the right lower side is an open hysterectomy, whereby the wound is at least supposed cm across, even though it's a fenestrial scar. Supposed cm across is quite painful. Usually, those in open surgery, we have to we have to keep the patient at least 2 nights, 2 days. So, and of course, the pain relief that patient minta lepas open surgery will be much higher. So we always have a IM petidine to stand by when they request every 4 hourly or 6 hourly. So there's a huge difference. Next slide. This is one of the many publications yang menunjukkan laparoscopy and open method ada banyak perbezaan, a huge difference in terms of pain. You can see those with the first column, those with no pain, 43 from the laparoscopy, and those with open surgery, there are only 19 have no pain. Whereas you look at the severe pain, only 2 patients from laparoscopic group having severe pain, whereas 11 patients dekat open group having severe pain. So the perbezaan is very significant. This is just the pain we are talking about. I have not talked about length of stay dekat hospital, the days of ambulation, bila boleh bergerak ambulation, and then bila boleh makan, start makan. All those are equally significant. This one, I just put a slide for pain saja. So this is where, because this comparison is easy. Many gynecologists, ONG specialists publish this paper, jenis paper macam itu. This is one of them. Okay, next slide. So selain daripada itu, many of our surgeons also try their best to inject dekat tempat yang sakit, like peri-articular knee joint injection during the knee replacement. So surrounding cut area, they also inject a little bit of local anesthetic. Even the laparoscopic procedure, many of my surgeons also try to infiltrate local anesthetic dekat the port site, the laparoscopic port. Biasanya ada 3 atau 4 ports pada abdomen, so they try to infiltrate quite a bit of local anesthetic in order to reduce the pain. Because all these small action will reduce significantly post-operative pain. So now we come to post-operatively. Next slide. Besides the ubat yang saya cakap tadi, like for instance the opioids, tramadol biasanya I don't give pre-op, I give post-op kalau perlu. Because tramadol have less effect on the respiratory, kurang buat respiratory bernafas perlahan, because kurang berkesan. But it is a weak one. It's a weak opioid. Maksud saya berkesan untuk kurang sakit, dia kurang baik daripada morfin atau petidine kalau dibandingkan. And the other thing is dia kerap membuat nausea atau vomiting. After the IM or IV tramadol, or even oral tramadol, quite a significant patients dapat nausea and vomiting, which is very unpleasant, especially during laparotomy. Kalau perut sudah ada satu scar dan you muntah lagi, the wound will be very, very painful. So sometimes tramadol is not my first choice for post-op pain relief. Next slide. And of course, these 10 years, we have so many new medications on board, including fentanyl patch, oxycontin. Oxycontin is oral form of oxynorm. Just now I show you one of the IV ubat, IV opioid is oxynorm. So oxycontin is the oral form. Boleh bagi makan 5, 10 milligram or even 20 milligram per day also can be used. The other one is Ultracet, paracetamol to get campur dengan tramadol, and Panadine is a codeine campur dengan Panadol. All those are the oral medication yang boleh pakai lepas operation when the patient start or even the discharge ubat for patient. Next slide. So apart from all those painkiller they are talking about, one ubat I want to stress here is a naloxone, because naloxone is direct opposite for opioid. It reverses the effects of opioid. So sometimes, especially in the elderly or the very young patient, when we give too much of opioid, let's say morphine or petidine, patient kurang bernafas atau kurang sedar diri. So we need to use naloxone to reverse. So naloxone is very important to be kept in the ward. Simpan di ward. Kalau tiba-tiba patient kurang bernafas atau terbagi banyak morphine atau petidine. So biasanya panggil doktor dulu. Okay, we'll come and give the ubat. Okay, next slide. Selain itu, patient control analgesia, PCA machine. PCA is very important. Why PCA important? Because it is a pump that deliver ubat. Sama ada opioids, maksud saya sama ada morphine atau petidin, dia deliver ke patient terus. And then patient yang control berapa banyak yang dia perlu. So selain daripada intravenous, epidural boleh bagi juga melalui PCA, and also subcute boleh bagi PCA. Next slide. So advantage is bila patient jaga terbangun dari tidur sebab sakit, dia akan tekan PCA machine itu. Oleh itu, the dose yang diperlukan dia akan match dengan kesakitan dia. Kalau dia tak sakit, very comfortable, dia tak akan tekan. So we don't overdose the patient, and then tak ada sakit juga, tak selalu kerap, kita tak kerap cucuk patient macam IM petidin. If we intramuscular injection, sometimes cause very painful. So, and the other thing is, staff tak perlu tiap-tiap 6 jam, tiap-tiap 8 jam bagi IM petidin atau bagi patient. So staff work akan kurang, and also it's a very good pain relief lah. Next slide. However, bukan semua orang sesuai untuk PCA. Kenapa? Banyak orang tak tahu macam mana pakai. Asyik tekan, tapi kita set tiap-tiap 5 minit boleh baru ada ubat. So some of them they do not know how to operate this PCA machine, and then and also most of the PCA machine we using morphine atau petidin. That's why still have complications of opiate like nausea and vomiting. And some of the older machine ada banyak masalah termasuk battery dah ada, dia punya mechanism tak berapa bagus, sudah longgar. That's why come up with a lot of alarms. Banyak our staff nurse instead of kurang kerja, lebih banyak kerja untuk silent alarm dia. Oleh itu lagi berteruk, and sometimes bila tak plug pada wall power supply, patient terus mati. Mesin terus mati. Oleh itu kena panggil NS datang balik, reset balik the program. Banyak how some of the machine, and yang lagi some of the patient because tersangkut pada PCA machine, mereka tak mau gerak, pergi tandas atau berdiri pun tak boleh because machine tersangkut pada wall elektrik. Tak berani tak cabut wall elektrik tu, sebab you cabut machine akan hitam gelap balik, akan off. Oleh itu mereka tak percaya ambulate, unable to ambulate due to the PCA machine. So trends have been changing. Next slide. This is the old machine. Banyak jenis. You tengok dari kiri sampai kanan lah. Old machine yang saya pakai kurang lebih 20 tahun dahulu. But now we try to improvise. Datang lebih banyak yang baru device. Next slide. So this is one of the latest PCA machine yang saya pakai di KPJ Kuching. So you tengok tak ada power supply. Tak payah sangkut pada wall electric power supply. It just macam itu saja. Dan ringan, patient bawa sendiri. So there's a clip dekat hujung sebelah kanan on the right hand side. The clip is a clip on the baju. So they pergi toilet, pergi mandi, pergi ke physio dekat tingkat bawah, all can be carried along with this PCY machine. So this device basically is just to pump the ubat, the morphine atau petidin ke dalam balloon itu. Balloon itu akan provide elastic mechanism untuk together with a regulator dekat machine, dekat device itu, dia akan control tiap 5 minit baru boleh ditekan, dan tiap kali ditekan baru 1 ml of morphine atau petidin boleh masuk pada patient. So it's very advanced nowadays and very cheap some more. It's a few hundred ringgit or not like a few thousand. So single use, very safe. It's more convenient to patients and also to clinician. So lepas 2 hari tak mau pakai, disconnect from the IV line dan buang saja. Okay, next slide. So apart from that, we also provide a lot of epidural anesthesia, especially yang dekat merah itu labor pain. A lot of our primary gravida patient yang datang untuk bersalin tak boleh tahan sakit sebab tak ada experience macam mana labor pain itu berasa. Some of them are very, very bad. Maksud saya sangat sakit sampai tak boleh teran, tak boleh push for the baby out. So labor pain actually can control very well with the labor epidural. So we in KPJ Kuching we give quite a lot of labor epidural because patient can rest well while waiting for the os to become 10 cm fully dilated. So patient akan simpan tenaga, jimat the tenaga untuk teran masa push the baby out, rather than for the last 5 or 6 hours terus jerit-menjerit about the sakit. So actually for labor pain, epidural analgesia is very, very effective, help a lot of young patients, young mothers. And of course, for those major laparotomy yang involve the epigastric, we also provide a lot of thoracic epidural, lumbar epidural as well. But it's just that there's a catch. Epidural, kita pakai yang machine yang sangkut pada electricity, banyak patient cannot ambulate. Even sit up also, they worry the epidural tercabut. Oleh itu, because can involve the migration of the catheter. So nowadays, with the development of banyak other jenis post-operative analgesia, for instance, the block, for instance, those PCA machine, PCA device, we cut down our epidural service already. We provide less epidural service except the labor pain for labor pain. Okay, next slide. So the advantage of epidural is a very good quality because it provides segmental block. Dekat mana you letak pada tulang belakang, it will be the segment. It's not the whole region. So sometimes you can block dekat T4 until T10. You can block until T12 until L5. So it's a very good segmental block without ganggu your pergerakan. So your kaki still can be very strong with minimal numbness. So and then this kind of analgesia, tak ada side effect of opiate macam sedation ke atau terlalu sleepy. So it also again single injection. Tak payah asyik datang tiap-tiap 4-6 jam untuk dapat IM petidine. But disadvantage is the epidural sometimes can cause a significant vessel dilatation. So it can cause hypotension and also bradycardia kalau kita tak adjust dosage dengan bagus. And sometimes masuk satu epidural catheter is technically challenging, a bit susah, especially patient yang ada sikit-sikit scoliosis atau patient yang terlalu tua, terlalu banyak bone spur dekat tulang belakang, sometimes a bit susah, we struggle. So even though we are quite experienced, but sometimes we struggle and then we abandon the procedure. And of course, like I say, with the epidural catheter, epidural tubing tu tersangkut pada belakang, banyak patient juga delay ambulation, tak mau bergerak, takut tercabut the catheter will come out during the movement. So again, delay. So this mode of analgesia also we cut down already. Okay, next slide. So another thing is a Q pump, which I would like to mention about here. Q pump basically is one or two small tubes letak directly into surgical site. Like for instance, so this Q pump, the catheter, one of the end will be letak dekat, for instance, knee replacement surgery. Q pump, the tip of the catheter will letak dekat fascia because fascia is the most painful. Sebelum surgeon close the wound dekat fascia, so they insert the catheter inside. So this Q pump sama dengan the latest model of the PCA device. Dia juga pakai elastic mechanism. You pump banyak air, banyak ubat ke dalam balloon itu akan tolak the ubat, which is the local anesthetic. And there's a mechanism, there's a regular dekat pump itu, so that it adjusts 5 to 10 minutes, 5 to 10 mils every hour to pump the ubat dekat the wound itu. So nowadays surgeons try to do a lot of this kind of improvise a lot of technique for post-operative analgesia. So Q pump in our center, KPJUCIAN, we provide Q pump service through the knee replacement surgery, also the scoliosis surgery, the spine surgery, whereby it significantly cut down the usage of opiate like petidine or morphine post-operative, and then patient less drowsy, early ambulation, early taking orally, because less opiate, patient they don't feel nauseous, they don't feel vomiting, so they eat earlier, and then and also they are more awake, easier to ambulate. Again, this Q pump doesn't require electric, tak perlu pasang electric, dia gantung pada baju patient saja. Oleh itu, bila patient bergerak, berdiri, pergi ke physio, pergi ke rehab, boleh pergi, tak ada electric, tak ada sambung electric. So it's very convenient, in fact. So nowadays, technology improve. Banyak benda, banyak how we need to know and we need to improvise. We need to follow the trend as well. Next slide. So again, Q pump, we can put Marcaine or Chirocaine, okay? And so it depends how many pumps we kita pakai. Usually we provide for 3 days, 2 to 3 days lah. So for nurses, we need to care whether the local anesthetic leak from the wound site, and then the tip bila my nurse cabut after 3 days, bila dia tarik keluar the tip itu, we need to make sure the tip is intact. Oh, tak tertinggal dalam wound itu. So that's my nursing monitoring and nursing observation buat untuk saya. Okay, next slide. So the other thing is a subcute morphine. So we put a small cannula dekat skin by the chest wall, so that superficially, so that we can inject the subcute morphine. For the, I mean, I'm a new anesthetist compared to those old school of thought. Some of them use quite a bit of subcute morphine, but I hardly use because we have so many type of method. Okay, next slide. So, but it's very easy and cheap. So you can see next slide. There's the photo of how the subcute morphine letak. Next slide. So letak a small cannula, letak a stopper, so that gum you just plaster dengan micropore dekat chest wall, upper chest wall. So senang nampak, and nurse typically datang cucuk pada stopper itu. 0.5 ml of morphine or 0.5 ml of petidine. So it's a slow release. So boleh tahan tiap-tiap 6 jam macam itu. Okay, next slide. So I want to stress a little bit of analgesia corridor, because when we give ubat, kalau kita tak bagi cukup, patient rasa sakit. Kalau kita bagi terlalu banyak, give too much, patient have a side effect like I mentioned just now, those slide. So there is a analgesia corridor, which is the green line, analgesia. And this analgesia corridor, it will changes with time. Next slide. That means once you give, the drug concentration dekat badan akan bertambah. Bila dia cukup, dia akan sampai ke kolom hijau itu, whereby we achieve analgesia. Tapi lepas dekat 6 jam, 8 jam, then the concentration dekat badan akan kurang. Dia will datang sakit balik. So before the 8 jam sakit, we need to inject lagi, bagi lagi ubat supaya the concentration dalam badan naik balik, supaya dapat achieve pain relief. So that's how it works. That's why we need some APS team, acute pain service team dekat hospital to monitor post-operative pain. Next slide. So nursing observation is very important. This is one of our a few of our nurses in our nursing counter doing monitoring, charting. Currently it's during COVID time. Most of them wearing a full PPE during observation. Why is nursing observation very important? Because they need to make sure adequate analgesia, effective analgesia is given to patient. Patient tak terlalu sakit, tak menangis di dalam bilik. Number 2, they help the doctor to detect any serious side effect. If there is any side effect, they will inform us immediately. Okay, next slide. And of course, as Dr. Haslan said, next slide, pain is the 5th vital sign. We need to monitor the pain score as well. So by monitoring the pain score, we can titrate the adequate amount of pain relief. Cukup, tak lebih, tak kurang, supaya patient dapat pain relief yang cukup. Supaya, because all this bergantung kepada berat badan dan umur badan. So that the best analgesia without any side effect. Next slide. And of course, this is one of the rulers similar to what Dr. Haslan yang tunjuk. Okay, we pakai ruler, we ask the patient to slide sama ada dari 0 sampai ke 100. So can roughly tell more objectively berapa banyak sakit yang patient terima. Next slide. So for nurse, because today my audience mainly are nurse, so need to let them to have some bring home message, especially most of the nurse involved in the ward, bekerja dekat ward, they are working in the ward. So what they do, especially post-operative pain patient, beside pain score, which is the 5th vital sign, the other 4 vital sign include blood pressure, pulse rate, respiratory rate, and also sedation score. All these need to be monitored when patient come out from OT during day 1, day 2, or day 3, because any of the day, things may happen if we do not monitor adequately. Kalau kita sikit longgar, lepak, sikit relax, sometimes we just miss some important sign. Next slide. So for sedation score, we don't need to make sure patients are easily arousable. Senang dipanggil. Oh, panggil apa? Oh, pacit. Patient terus buka mata. So we need to make sure patient tekan skor nombor 2. Bila tekan skor nombor 3 atau terlalu kuat sleeping, then we have to be very careful. Maybe you need to warn the involved consultant, the primary doctor. Next slide. So the other thing is, what should we do? Like usual, hourly for first 4 hours and then subsequently every 4 hours if patient is stable. If kalau masih tak stable, then still hourly, or in fact, some consultant may order half hourly monitoring. Keep on monitoring. Next slide. So as a nurse, when you plan to call, apa yang berlaku bila you call the APS, bila baru you call kita consultant. So when the sedation score is 2 and then the respiratory rate is less than 8. Because normal people, nafas is kurang lebih 12-15 kali. When you put on the pulse oximeter, some of pulse oximeter can see the respiratory rate. Kalau 6-7 respiratory rate per minute or breath rate per minute, cepat-cepat inform the involved doctor. Kalau sedation score is more than 3, straight away inform the doctor also, because it's too sleepy, cannot be arousable, tak boleh dijagakan. Or pain score is more than 4, also call doctor, because inadequate pain relief also, we need to tambah lagi ubat. And patient asyik muntah, also call doctor. And one more thing, systolic blood pressure. The blood pressure dekat atas itu systolic less than 80, cepat-cepat inform. All this can save life if you inform early, just in time. Kalau tidak, things may happen, termasuk hypoxemia, stroke, heart attack. All these things can happen if BP too low or respiratory rate too little, kurang oxygen. Because what we can do, next slide, we can panggil the pacit, okay, give oxygen, try to wake up the pacit, and then we stop whatever infusion, sama ada epidural atau PCA, disconnect dulu, PCA morphine, disconnect sekejap dulu. And then kalau memang tahu is the opioid yang bermasalah, then prepare the naloxone sebelum doktor mari. Because if the doctor come, they straight order, jangan masa itu baru cari naloxone. Pergi ke central pharmacy ambil 1 ampule naloxone. I think it's a bit too late lah. Because central pharmacy kena check, kena key in the code, semua computerized. Mungkin ambil 45 minutes baru dapat the naloxone. Kalau you know that is due to opioid, jangan tunggu doktor order. Terus prepare dulu, because the chances that doctor need naloxone to reverse the effect of opioid very high. They will definitely ask, mana naloxone? Our smart nurses will say, doctor, sudah sedia ada. Wow, that's the best. Best for everybody, for patient especially, because you save one life. Okay, next. So selain menjadi anesthetist, besides becoming an anesthetist, I also do quite a bit of interventional pain. I inject a lot of those. I do a bit of radio frequency to my patient. So post-operatively is quite painful. That's why I also need my nurse, my APN nurse, to monitor the pain and then report back to me. Patient tak terlalu sakit. So in order to get all this best outcome, I really need a teamwork, because next slide. Only teamwork only will ensure the success of a hospital, will ensure the best interest of the patient will be well taken care. Okay, with that, I thank you everyone for listening. Thank you very much. Good. Any questions would you like to address to me?
Thanks, Dr. Chen, for the informative talk. So I hope you also very enjoy with this talk given by Dr. Chen. So okay, I have 2 questions posed in the group chat. First, doctors, they'll ask, the question is, why a lot of having itchiness post-operative with spinal morphine? What is the best release?
So one of my slides actually demonstrate that opioids can increase the histamine release. One of the side effects of opioids, not many people, we are talking about 10%, 15% of patients may develop mild histamine release. So allergic reaction, like for instance, a bit of rashes, or some rashes, some of the itchiness could be quite annoying, sangat mengganggukan, especially the perianal rashes or other berlaku, because keep on stretching dekat bahagian itu perianal is not very pleasant, and then we notice that it's due to our spinal, because some of our spinal, especially like Caesar, beside the heavy marcaine, I also gives a little bit of fentanyl. They're allergic to fentanyl, so but it's a short lasting, meaning that tak akan berlanjutan, it won't last very long, and then usually we give some Piriton. We give some Piriton, it will relieve it. Because by the time the spinal, after 4 hours, the spinal effect will be reduced, will be over, the histamine release also will be over, and then the itchiness, the allergic reaction will be disappear as well. But I mean, during early phase, mother or the pregnant mother or the patient takut sangat, oh gatal, and then our nurses pun rasa tak selesa, so we provide IV Piriton. Sometimes plus or minus give a little bit of steroid also, like just like management of allergic reaction. No worry, it's quite common, happens also.
Okay, thanks for the answer. So another question is, what is the best pain management for the laparotomy? So for advice from doctors.
Okay, this kind of thing have to start from pre, intra, and post-op. So laparotomy definitely has to be under GA. GA. So if the anesthetist is comfortable with block, let's say transversus abdominis plain block, like what I usually do, so we can give this kind of block before the surgeon cuts open. Okay, and if you are more comfortable with thoracic epidural or high lumbar epidural dekat L1 or L2, then go ahead. Epidural also doing very well. So I mean, there's no best or not best. It really depends on the comfort of the anesthetist who provide anesthesia. Then question number 2 is whether this laparotomy is suitable for laparoscopic or open or not. That also depends. What is your condition? Whether it's a cancer or just removal of fibroid. So again, discuss with your surgeon which is the best outcome for that kind of masala, for that kind of illness. Because if can be done by laparoscopically, can deliver the fibroid, can deliver the uterus through laparoscopically, then why not? You use a laparoscopic 3 lubang pada perut saja, 3 ports only, can settle the one large midline scar. Why not, right? So that definitely will reduce the pain after operation. Okay, and of course, the lastly, post-operatively, it depends on the age and also the underlying condition. If the patient is fit and well, we can generously give Acoxia, Cerebrex, or PCA pump to the patient for pain relief. Because I mean, there's no straightforward answer for what is the most suitable pain relief for laparotomy. So banyak factor we need to see both by the surgery and the patient itself. So yeah, for the Q pump, which company to purchase? I think you have to. I have to refer back this question to our sister Ang yang kerja dekat OT. She will be having all the contacts. So later maybe I will ask Sister Ang to share the contact of where to get the Q pump. Share with Matron Lee. Is it alright? Ask Sister Ang to pass you the contact so that more people will be aware of the usage, what is the right indication. All this will benefit the patient, especially post-operative pain management. So any other questions?
Yes, doctor, the last question is that so the question is why post-seizure after the spinal gone will be very painful?
Well, that really depends whether our anesthetist together with the obstetrician pakar sakit puan itu overlap the spinal anesthesia with other opiate with other ubat or not. For instance, I share with you my experience, our experience dekat KPJ Kuching. So usually the spinal anesthesia or spinal for Caesar will last for 4 hours. Kurang lebih after operation 4 hours, patient still after 4 hours, patient baru start to feel pain. So immediately after operation, patient very happy, very comfortable for next 3 hours. But before the pain arise, during the operation, when our nurses doing the dressing lepas operation di dalam OT, our O&G specialists and also myself, we encourage the use of suppository diclofenac 2 biji, like 100 milligram, 2 biji 100 milligram. So because it takes time to work, suppository, even though you put inside the anus, it takes time to work. So let's say it works half an hour, 1 hour later, but that time it already overlapped with your spinal. Spinal still not yet wear off. Masih ada kesan spinal, masih tak sakit lagi. Tapi bila spinal wear off, our diclofenac suppository sudah berkesan. That's number one. Number two, immediately post-op, masa the spinal still working, our APS nurse, our nurse dekat ward also serve 2 biji Panadol 1 gram. So it's very effective. And of course, we also stand by a lot of IM petidine, 100 milligram 4 hourly at least, to ensure they are comfortable, not like screaming in pain or refuse to provide a breast milk to patient because laparotomy, because of the Caesar wound. So we hardly have this kind of incident. Basically, we don't have. I never encountered a patient terlalu sakit that patient menangis after Caesar. So I think it's very painful. Maybe need to modify, like for instance, overlap the spinal anesthesia together with some suppository and also together with some oral medication. Because patient can given oral immediately post-op. Why? It's a spinal. It's not GA. Patient is very awake. They are awake to see the baby and also awake to take photos with the baby during the surgery. So it's a very happy moment for us. Any questions?
I think it's a very, very last question. Okay. What type of the case that require regional block?
Well, regional block really depend on anesthesiologists like myself and my colleague, Dr. Francis, and like Dr. Haslan. So whether we are comfortable, whether we are good. You see, if you are not good, straight away just GA, give a lot of morphine, and then post-op, give a lot of morphine as well. So also settle the whole thing. But like regional man like me, meaning that I provide anesthesia, I can do a radius ulnar fracture by just giving a brachial plexus block. Patient awake, but just the one arm cannot move because I give adequate block dekat leher. So where the brachial plexus travel, the whole arm cannot move, cannot feel, and last for 8 hours. So surgeon finish the surgery with 1 hour, no problem. And our surgeon like Dr. Lee Wu Guan, the KPJUCIAN'S orthopedic surgeon, is very, very fond of pierce block. He does the radius ulnar fracture within half an hour. So we use a tourniquet to provide pierce block. The pierce block is just like injecting a local anesthetic dekat tangan saja. So radius ulnar block within 45 minutes, 2 bones within 45 minutes can settle. So patient discharge post-op. Again, actually, for all kind of surgery, we can provide block. Like amputation of one or big toe, we can provide ankle block. Or like for knee replacement surgery or BKA, below knee amputation, we can provide femoral together with sciatic nerve block. Okay, and then for laparotomy, we can provide TAP block, trans abdominis, transversus abdominis plane block, or even putting a catheter while putting doing the block also can. And brachial plexus block also can put a catheter. So right now we involve the femoral nerve block, we evolve to adductor canal block. So all these things have been changing, improving. It's just that it's not like what regional anesthesia for what surgery. You need to know whether the anesthetic is comfortable to provide that kind of block or not. Because if you are not comfortable to provide and you try to provide patchy block, separuh jalan, separuh tak jalan, that will be not very nice. Then convert to GA, that kind of thing. Do you understand? Or you have already in mind, perlu overlap. GA together with a block. So this kind of thing need planning and also depends on the nature of surgery. Even our cleft lips, we can provide a infraorbital block dekat muka in order patient wake up, the neonate wake up, bangun, tak menangis terlalu kuat. Bila dia menangis kuat, the suture pada lips boleh retak, can open. We don't want them to cry. So we numb the lips by using infraorbital nerve block. I do that also. So again, like I say, some may know, some anesthetists may not know. Very difficult to judge because, of course, our gold standard will be GA. Anything boleh GA. We are very good at intubation, so no doubt about that. Because intubation is our core skill, kemahiran paling muktamad. Would you agree? Any anesthetist will know, must know intubation. Put a tube into a throat. So what I say is, like I say, the comfort of the anesthetist. So very difficult to answer this question. No straightforward answer. I'm so sorry about that.
Okay, thanks.
Any more questions?
Yeah. So okay, no more already. But any extra question because of time constraint, later we will you can put in the chat box and then we will send to Dr. Chen for answer. So okay, thank you, Dr. Chen again. So and then for very informative talk to us, sharing to us, and then behalf from cohort 5B group, we would like to express our gratitude to both speakers who willing to spend their time with us to deliver a very informative talk which beneficial for our nurses throughout their care on post-operative patients. And then thank you very much. So thanks again, Dr. Chen. So for
No
sure,
problem. See you again.
yeah, thanks. And then also I know I also use this platform to thanks for the KPJUC, our Puan Teh Halimatum, and then Puan Shamilan, and then also Izzat Aizuddin to assist us to make this webinar very successful. Thank you so much.
Sure. Hopefully next time we'll do a physical one. We meet up in your college. We meet up in your college, okay?
Yes, it's really. But then now it's because hopefully after pandemic we'll be getting settled, we can meet up together. Okay, thank you so much.
Okay, take care, everybody. Take care.
Thank you, everyone.
Thanks, Haslan. Nice to meet you, Haslan.
Yeah, Chen.